ladies and gentlemen, and thanks to those who have hung around for the last talks of today. May I say I'm honoured to be here and to thank Shafi and the team for inviting me. It's the first meeting of this type that I've ever been to. I'm a novice when it comes to the digital age, although I did reflect and add to this slide, and you can see the link there at the bottom, that actually I've had a 37-year hiatus from IT. I wrote or helped write the basic binary code for a computer game on the ZX Spectrum, the 48K ZX Spectrum, when I was 14. But since that time, I've done almost nothing with computing, and so I returned today to re-engage with it. So future challenges for surgical research and opportunities for technology. Much of surgical research, but not all of it, is concerned with the outcomes of the procedures that we perform. And here is some of my artwork, which is about the sort of graphics level of the ZX Spectrum back in the early 80s. A man or a woman goes in for an operation. They have that operation, and they have an outcome from that operation. Here, an amputation. We have a pre-morbid state, an intervention, and we have an outcome. And we love the randomized controlled trial. The randomized controlled trial, for those not involved in research, is really the best of a bad design that we have. 1948 streptomycin MRC trial, relatively recent invention. And there are many advantages of the randomized controlled trial in reducing bias. Here's what we do. We have a population of interest. One population has one intervention, another has another, or hopefully a sham intervention, and we compare the outcomes between those two groups. There are many problems, however, with using randomized controlled trials for surgical or indeed other complex interventions, many of which are not present when you perform drug trials. These are problems of internal validity, notably the difficulty of finding a sham or a placebo or comparator, blinding, which can be very difficult, and the fidelity of the intervention, i.e. that with a complex intervention, there is a tendency to change it as one goes on. There's also a problem of patient preference, surgeon equipoise, and Buxton's law. That is, when you have a new innovation, people don't want to adopt it early because they're scared, and by the time they do and you get to do a trial, your results are already too late. External validity. Many of the things are out of date by completion because we take too long to do trials. Unmeasured distant harms, which are not measured in the trial envelope, and they're not real world because of the nature of their design. And at least in the UK, the average trial lasts 4 years, costs £1.5 million, and 45% of trials fail to achieve their target sample size, despite 80% of them requiring an extension to their recruitment period. And this is what happens in reality in a surgical trial. Consider a mixed population of patients. Some are blue, some are red, some are orange, undergoing an intervention. Surgeon 1 will not operate on red people. Surgeon 2 will not perform the alternative procedure on orange people. And so you have an outcome that is only in blue people. The interpretation of that is that the new device is superior, but don't mention that it's only in blue people. The new device is inferior, but that's because we included the wrong population, blue people, or the study took so long to find the blue people that it was never achieved at all. And this is the reality with randomized trials. So I'm going to revisit the natural experiment, an observational design, commonly called cohort studies. And I'm going to introduce to what I showed you before, the variable of time. And for the rest of this talk, I will talk about before and after and an intervention. Here's a typical cohort study. We have a patient before their operation. We measure the usual things. We measure lots of things about their operation, how long it took, how long they stayed in hospital, what were their complications, and we follow them up for a short period of time and measure the usual things like disease-related outcomes. And worse still, we measure this thing, a global rating score, where patients report back whether they're satisfied or not with their operation. And the problem with such studies is our friend bias. So we select patients that we think may do well, that's selection bias. When we observe something, we change the way we do it. That's the Hawthorne effect observed in Chicago in a factory. We conveniently exclude patients who are lost because things went wrong, usually caused because their procedure changes. And we report these outcomes back to the very people like me and Shafi, who did their operation. And of course, we have a relationship with patients, hopefully, a good one. And patients don't like telling you that you did a terrible job. You've invested time in them. And then, of course, we have editors who love a p-value on a paired t-test, which is quite the wrong way of analysing them. And so on this basis, we can gain almost nothing from that sort of style. So one of the problems of cohort studies is that we're obsessed with the operation and how we do it. We measure all those things very well. We don't measure multimorbidity very well at baseline, which affects outcomes much more than the way Shafi and I perform an operation. We don't measure long-term functional outcomes, which are much more important for the patient, particularly because now they're going to live longer, because we all live longer, and they will have to bear the outcomes of their surgery. Remember, surgery is a chronic disease. You will never be quite the same after you've had surgery, particularly if you have multiple surgeries. And of course, we don't detect late harms, and we've learnt this from the Dupuy hip saga and the breast implant saga recently. So a better cohort study would be one that recorded all these outcomes, multimorbidity at baseline, looked at all the adjuncts of care in detail that make a difference to outcome, and then followed people up with relevant quality of life outcomes for a long period of time, say 5 years. The problem is that no one will fund such studies. They're unpopular. So here we are in summary. The problems with cohort studies as they stand are that we have every imaginable type of bias. We have a lack of meaningful data over time, particularly valid measures of quality of life and later harms. And we also have a lack of statistical power, even if that's been considered in the study design. So what I said at a meeting some time ago is observational studies are not fundamentally bad. We, surgeons, just do them very badly. Now, I've not come here with bad news and set a load of problems without a potential solution. And my solution requires 4 things. It requires the variable of time. Remember, time is a variable. It's a secular trend. Statisticians like me like time because it's important. You need willing patients. You need a platform, which I'll come back to. And you need a clever statistician. And my next part of the talk will include some medical statistics, for which I apologize. There is a little-known branch of statistics called N-of-1 studies. N-of-1 studies, as an illustration here. Someone eats something, they feel ill. Well, it must have been that thing I ate because it's temporally associated with the thing. But it's too bad I don't have a proper control group to know whether the bad tuna was in fact the thing that caused me. And this is a time series, okay? That single individual has a time series of their state, their behavior, which can be looked at in the context of events and their perception of them. And this is used in the psychobehavioral literature quite a lot. If we move on and we have more than one individual, we can see that we could generate similar changes in an event or time and outcome, a prom, a score, that related to various events in the manner shown on here. And there is a branch of mathematical statistics that is concerned with these N-of-1 studies. And that branch is considering that these represent a regression line. So these are individual level. They're an interrupted time series of points that change because an event or an intervention occurs. And here we see those same 3 people graphically represented, but you could imagine that we could take the same 3 people and we could align them around that event. And here you get the sense of what you can do. And that is, and we like this as statisticians and researchers, we can plot a confidence interval with many people who have undergone the same intervention to see what the effect of that is on their time series. So here you have a deviation or an interruption, as we call it, in the regression line. And if you have 2 interventions or 2 events, you could look at the difference that those caused. And there are a considerable amount of maths and an interest in this area. But I'm going to draw your attention to one other thing which I won't cover in detail, and that is that in the randomized trial design area, one thing I'm also interested in is in randomized sequences of interventions. And the classic example of this is the step wedge randomized trial. Now here you can see, and I've labeled it B and A for you, we've got people with a variable amount of B time and a variable amount of A time. And that's very like the things I've already been talking to you about. here we go. We're looking at this again. Here we've got people before and after, and they've got a different number of Bs and a different number of As. Well, if we consider that that is quasi-random, then we have an experimental design embedded in a natural experiment, in an observational design. And the advantage of that from a statistical point of view is that patients can act both as sequential and concurrent controls. And I'm not going to go into the maths, but it's published by myself and Richard Hooper. But you can demonstrate by the maths of that that is statistically more efficient than looking simply at comparing data before and after in individuals. It increases statistical power. The next thing you need is patience. Here's one of my patients, Leslie. I've said she's a future N of 1. N of 1 in the study. 40 years of bowel disease, she's had multiple operations, and she told me the other day, I was at a meeting completely unrelated, in fact in relation to a randomized trial, that no one ever collects my outcome data. No one's ever asked me how I feel after an operation a long time after. And geez, I don't know how old Leslie is, I didn't ask her age, one shouldn't as a gentleman. But she would happily collect her data in the long term, including using digital devices. And of course, many people feel the same way about that. And because few interventions are given with the certainty of 100% success, really every patient is a suitable candidate for such data collection. So here's an enhanced cohort study. Here we have an individual before at various time points and after they move along the thing with the thing. And we have, and I've shown it here as the promise, this is an NIHR-funded platform which collects these data at a hub away from the hospital where the intervention occurred, and we can follow that patient's data, and during the time that's happening, they may have had an intervention. They may have had one operation or another operation, and we don't know the timing of that intervention or what they've had done, so we're blind in the way we would be in a randomized trial to knowing what that has until the data are cleaned, locked, and we can analyze that with the enhancements that a randomized trial has. And when you have hundreds of those and a clever statistician, you can do a blinded interrupted regression analysis and get a powerful outcome from it. I've shown you this slide already. It's about bias. If you look carefully at what I've told you and you've listened earlier, you will realize that all bias is in the eye of the beholder. The patient themselves doesn't generate bias. I generate bias by looking at it, unintentionally or intentionally. And that's the problem with all of those sources of bias. And we've heard many people who know much more about the quantified self than I do here, and we've heard about very complex data collections with patients. But we can imagine a situation where if the patient managed that data collection, and they, rather than us influencing it, that bias would be removed. The other advantage of a patient collecting their data is that they can curate their data as they go along. And Flatiron, and this is just an example, the data we get from routine data is so poor and so misaligned with each other in so many different forms that it requires mechanical Turk-style crowdsourcing to actually work through the human errors in this data. Whereas you could have one curator per data set, the patient, if they're invested in this, has an enormous advantage. So this is the future, the 2025 Enhanced Surgical Cohort Study. It's patient curated. It uses let's say a website in the cloud. That's your business, not mine. That's an area that I don't understand well. But the patient accessing this collects their data longitudinally at stepped time points. During that period of time, they will undergo an intervention, let's say, maybe a surgical intervention or something else we're interested in. 8 million procedures occur in the NHS in England per annum, and all of these are an opportunity to evaluate outcomes. The patient can update their multimorbidity. 2 slides to go, am I all right? Yeah. So, and they may have one or they may have more interventions as shown here during that period of time. We then have thousands of patients which when combined with the routine data, which we do collect, we know what operations they've had, allow us to blindly analyze what the real outcomes of these patients are. And that, I believe, is the future. My last slides, I'm a country musician, as some of you know, is note on secular trends. I said time's a really important variable, but things change over time. And during time, all sorts of things can happen to your quality of life. So your dog dies, your wife and kids leave you. They invent self-drive cars, and then your truck leaves you. But then your record may go platinum, the life of a country musician. And these things we totally ignore. So we measure quality of life in ignorance of what the patient's happiness or other things, you know, anxiety and pain, we heard it from the last speaker, of their life events are on their outcomes. And also with age, of course, multimorbidity, frailty, etc. So we need to include that, and the patient can include that for you if we collect that in the right way. With then big data, and I would suggest that we will need Bayesian networks to manage AI in this context, but that's my own personal view, we will be able to make sense of what quality of life really looks like over time and how our interventions influence it. And if you really want to go the whole hog and mix the phenome and the genome in with that and how you respond to these interventions, that's where the future will lie. And patients, I believe, as many other speakers have said here today, own their data. They are the owners, the rightful owners, and the curators of their data. I would hope that some would donate it to people like me so we can analyze what the real results of interventions are, but they could sell it, and that would be fine. So this is all we need. I said time, willing patients, clever statistician, and the reason I'm here, or part of the reason I'm here, is I need people like you who understand the building of a platform to support the ideas that I have today. Thank you very much.